he showed that by researching the world literature that this reduced the incidence of colds tremendously, but it didn't actually cure them usually. Now, Klinner previously actually had cured polio. And if you look at my website, OrthoMedCom, we have the original article where Klinner cured 60 cases of polio out of 60 with intravenous sodium ascorbate. And he also said ascorbic acid. This has created confusion all along. And as a matter of fact, sometimes when you buy these solutions, they'll be labeled ascorbic acid, but then you look in the fine print and you'll see that it's been buffered with sodium hydroxide or sodium carbonate. So this makes it sodium ascorbate. But anyway, as far as the treatment of any viral disease, I want to refresh you about where my role in vitamin C is really this developing of the titration to bowel tolerance with ascorbic acid. And what I discovered in 1969 is the average person with a good stomach can take from 10 to 15 grams of ascorbic acid divided up into 4 to 6 doses per 24 hours before it produces diarrhea. Now, it's not really diarrhea, it's sort of a watery runoff, but it doesn't usually hurt and all that. Now, I know a lot of people out here will have trouble with ascorbic acid, and there are special cases. It's interesting, while I was up at Incline between 1970 and 1980, I don't recall ever running into anybody who had trouble taking ascorbic acid. Now, we had a young population up there, kids and young adults, skiers and snow skiers, water skiers, and all this kind of thing, and they came in with their colds and their flus and their hepatitis and their mononucleosis and their gonorrhea and syphilis and all that, but other than that, they were perfectly well. Now, these people,
healthy sick.
The average person, the average person in this world has a cast iron immune system, our stomach, you might say. Yeah, and what I found from when I came down and gave a talk to the Orthomolecular Medical Society, and there are all the fellow travelers in there with chronic fatigue and so forth, that there were more people in that room that claimed to have trouble taking ascorbic acid than I had ever seen before. Now, I want to say that I'm sure that this audience here is more reflective of the type of people that I saw at the Orthomolecular Medical Society. So some of you will have trouble taking ascorbic acid, but Joe Blow off the street, who drinks his beer and eats sugar and still is not dead with his heart attack yet, can take ascorbic acid like it was going out of style. Now, this thing, what we found was that these people could take like 10 to 15 grams of ascorbic acid when they were perfectly well. But the astonishing thing was when they had a mild cold, they could take 30 to 60 grams, a bad cold 100 grams, a flu 150 grams, and mononucleosis sometimes in excess of 200 grams per 24 hours before it produced diarrhea. Now, this was astonishing. This blew my mind, and this is why I quit orthopedic surgery to go into orthomolecular medicine. Because here I thought that I had discovered the cure for all these viral diseases and I'd get a Nobel Prize and all that, and I didn't realize I was going to be in a lifelong fight with the medical profession over this. But anyway, the thing is that this titration to bowel tolerance indicates a few things. First of all, the enormous burnup of vitamin C when you're sick, the potential burnup if it's there. And the second thing is there was a threshold effect. That is, if you have what I call a 100-gram cold, and let's say you're this sick, and you start taking vitamin C 10, 20, 30, 40, no better, 60, 70, 80, 90, suddenly there is a drop-off of the symptoms. And what I think is happening is at that point is that we're forcing a reducing redox potential into the tissues involved by the disease. Now, okay, I'll say this in English. But oxidation reduction reaction in chemistry. Oxidation means a molecule is lacking in electrons, and reduction means that it has plenty of electrons, and it's a reducing substance is one that is able to give electrons and neutralize oxidizing substances. So all of these free radicals that we keep hearing about are all oxidizing substances. And in fact, philosophically, I think that we are these organic animals that are operating in this oxygen atmosphere that we burn for energy. But we have to have the defenses to keep from getting rusted. You know, like if you cut an apple or a banana, it turns brown immediately. Well, we don't do that because we have these antioxidants in our system, and that prevents this oxidation of the tissues. Well, I would think that diseases in general have found that if they screw up this antioxidant system and create all these free radicals in the body, that this almost paralyzes the immune system's ability to fight off the virus. So anytime you damage a cell, you're going to start producing free radicals. Now, to take you through a common cold is, everybody here I'm sure has had the experience of feeling like they were catching a cold one evening, but the next day they all wake up all well and they just forget about it. Well, what's happened there is either they have antibodies from a previous cold, or the white cells have managed to kill off the few viruses in the nose and throat. Well, but white cells are totally dependent upon vitamin C for their killing ability, and if there's no vitamin C, the white cells can't fight at all, you see. So you can see that if you take low maintenance doses of vitamin C, it is more difficult for the virus to produce this acute induced scurvy in the nose and throat. You see, what happens is the initial infection, by damaging the cells in the nose and throat, create all these free radicals that destroy all the vitamin C, so the white cells shut down. Now, when that happens, that's when you wake up in the morning and you realize, I'm going to be sick for a week to 10 days. Then this inflammatory free radical cascade starts. Now, what I mean by that is that when a free radical damages a cell, it makes that cell put out more free radicals onto adjacent cells, and this huge free radical cascade starts in the nose and throat, you see. And so this is why that the doses, appalling doses, up to 10, 15, 20 grams, simply will not force a reducing redox potential onto the nose and throat at that point. However, that then this acute induced scurvy spreads sometimes into the bronchial tubes, into the ears, and into the sinuses. Well, now obviously, if you are taking maybe 20 grams a day, or some moderate doses, it's going to be more difficult for that acute induced scurvy to spread into adjacent areas. So it reduces the complications of colds tremendously, you see. Okay, but if then you really want to treat the cold in the nose and throat, you have to push these doses up to about 90% of bowel tolerance, and that's of a real tough person, and usually that does. Sometimes we have to go intravenously with sodium ascorbate, but I generally don't do that just for a cold. But anyway, that's what we're trying to do, is to force a reducing redox potential onto the tissues of the tissue involved in the disease. Now, don't tell anybody outside who's a vitamin C hater that I said this, but there's a very interesting situation, is that you create a situation what I call unsick. If you can't knock the coal out completely at first, you get this where you're suppressing 90% of the symptoms. You never get complications, but you know you've got the cold. It's not that your nose is stuffy, and it's not that you're coughing and sneezing, but you get the message that if you quit the vitamin C in high dosage, you're going to get sick all over again. And I call this being unsick. Now, the interesting thing is that you may stay, if you're a really good vitamin C taker and you can't quite knock out the cold, you'll stay unsick for a day or two longer than you would have been uncomplicated sick. Now, the reason for that is that by neutralizing the free radicals that stimulate the B cells to make antibodies, you actually delay the antibodies from knocking the cold off completely. So you may stay unsick for a day or two longer, but nobody is worried about that situation. It absolutely, it's a fair trade-off, and I've never had anybody say that they didn't like that way to go. Now then we get into these flus, like to 100 to 150 grams, and that's the thing I want to emphasize, is that by taking vitamin C and all these other nutrients that help the immune system, you may prevent a lot of these flus, and you may prevent complications. But if you really get sick, I want to tell you, you have got to push these doses far beyond anything that most people here have considered. And the astonishing thing is that you can do it. Now, I would want you to practice a little bit with this. And I would also think that you should buy and have a store of ascorbic acid at home. Because I'm not kidding you, I can remember in the 1970s where there were a few flu epidemics where you could not get vitamin C in any store. It just ran out completely. Now their supply is pretty good now, but if we get an epidemic of this bird flu, I'll bet you can't buy vitamin C anywhere, that we're going to run out. So get your stores. And so anyway, I wanted to go through there, and I wonder if anybody had any questions about this, because the thing is that you've got to use these massive doses to make it work if you really get sick.
You know, this is unexpected, and it's so valuable and so important because, I mean, we are looking at this flu epidemic. Just, you know, the science is pretty much in consensus that it's going to happen. It's just a question of when. So I let it go, but I don't want to take any more time tonight with it. We'll come back to it and take up Steve on his kind offer, and maybe get Bob in on that too. Because I would like to have a protocol, including go out and buy ascorbic acid, just like you're saying about. And so I have in my home, you know, whatever I need, colloidal silver and all the good stuff to prepare. Because I'm telling you, you're going to see more and more about this. This is not speculation. But anyway. The only good thing that could happen is the flu might somehow attenuate as it travels around the globe, as Steve says. That's the only thing, the good thing that could happen. So by the time it gets to us, maybe only killing 10% instead of 50%. And one other thing I hope you all pick up on Steve's point that selenium is essential. Everybody in this room should be sure you have enough selenium. It is so important in protecting yourself against viruses and cancer. So, you know, that's probably the number one thing to do. But now I want to stop. I want to make one announcement. Then we'll take a short break, and then we'll go into the panel. And so now, I'm very happy to tell you that I think Smart Life Forum is going to make an important step forward. Mike and I have been talking about how we can reach out to some of the potential speakers that we haven't been getting to, because Mike has been doing a tremendous job. As you know, we have been getting really nationally famous speakers month after month. And what he does is he goes around to conferences all over the country, and he networks with people, and he's extremely good at persuading them to come out here and talk to us. And so his no charge. And so his network is primarily the medical practitioners, the pioneers in the medical field. There's also a scientific community, which is working on things like stem cells, on things like the miracle mouse, which when I first got it, I hesitated to pass it out. It sounded so much like a joke, it couldn't even be true. But then I talked to John Ferber. He was over in England giving a talk on glycation. At the talk on, you know the fellow, he spoke to us about the fellow that has the 7 ways we age, and then he thinks we can engineer negligible senescence. He can engineer almost no aging. Ugly, right. But he was over there at that conference, gave a talk, heard the guy talk about the miracle mouse, who did the miracle mouse work, and that's another thing I passed out. So now, we want to get people like that too, right? We want to miss any miracles in this group. So fortunately, Dick Motta had spoken to me and volunteered to do some work for us. And so we're giving him that project to reach out to the scientific community in the Bay Area and the West Coast, including Buck Institute, Linus Pauling Institute, the stem cell people in the Bay Area, the biotech community, the private companies. And so I wanted to just welcome Dick, and before I have him stand up, I want to just tell you that he grew up in New York City. And then he went to school down in Florida, all the way through University of Florida, got his PhD in electrical engineering, and worked in the physics of transistors, wrote his dissertation in physics of transistors, worked for, let's see what companies, let me see, I didn't realize I knew so much of it without even looking at my notes here, but the companies he worked for, National Semi, worked for Zilog, then he was a founding team member of Paradigm Technology, and he lives in Las Gatos with his wife, who's in the health field, Rebecca. So Dick, why don't you stand up? I'd like to welcome you to the board. Thanks very much. We're going to put to work. Mike and I are going to get together. We're going to get him oriented, and he's going to be working hard. So that's it. Now let's just take I'm going to have a break in the middle of the panel, but I want to take a short break now. Pam, what is it?
I just want to ask one quick question. Is this bird flu going to affect cats and dogs?
I don't know.
Birds?
I don't know. I think it would, but I don't know. See, cats and dogs, manufacture vitamin C. That's one thing. So I don't know. Yeah. But anyway, let's take just a quick break, and then we'll have our major break about 8:30 or so. Let's just why don't you stand and stretch, and then we'll introduce the minutes. And I brought my stopwatch right here. At the end of 5 minutes, I'm going to say 2 minutes. At the end of 7 minutes, I'm going to say time. We're going to go to the next person. Then, when each panelist has had an opening statement, kind of what's on their mind, what's salient for them right now, with respect to heart disease, or AKA really artery disease, then we will open the floor to your questions. And go on for a little while, half hour or so, and then we're going to take a 15-minute break. We'll come back, and we'll have them, each panelist say what they're thinking now, having heard where the discussion has gone. Again, briefly, and then we'll open up the floor, and we'll stop at 9:45 no matter what. How's that? Okay, now, as I say, this is a very distinguished panel. I'm going to introduce them one at a time in alphabetical order, and have them present in alphabetical order. And yeah, sorry?
Rigged.
I couldn't hear you.
That's rigged.
Rigged. I don't think so. I mean, you can start anywhere.
We didn't know this.
No, they didn't even know what the format was. I mean, this is completely unrehearsed, live. Like, you don't see this very often anymore. Okay, now, so the first speakers, the order of speakers will be Brauer, Cathcart, Fowkes, and Miller. Now, just like to introduce first Alan. Alan practices in Palo Alto. He happens to be my own anti-aging physician. I found him in about 1992-93, thanks to the recommendation of Steve Fowkes, for whom I am grateful for many, many things, including the reference to Alan. And at the time, I was looking for a way to explore Depronel, the drug Depronel, as an anti-aging drug. And Alan was able to tell me that I wasn't feeling so good because I had organic brain dysfunction, which is what you get when you're about 55. and I started taking Depronel, and I must say that it has changed my life along with a lot of other things, so that I think I have probably less organic brain dysfunction now than then, although probably that some of you may wonder about that. Alan is a man of many talents and interests. He also wrote a very well-known book on the enhancement of sexual orgasm. So I give you Alan Brauer.
Thanks, Phil. Completely unrehearsed, because I'm just not knowing the format either, and not having prepared anything. But nonetheless, I see a lot of folks who have cardiovascular problems and a variety of emotional problems. I guess I was first struck with a connection when I was a resident at Stanford doing a research study on the effects of stress and blood pressure. And one of the first people that I saw was a man who had been having a major, just recovered from a major MI that he'd experienced while watching the 49ers football game. And his wife said that he passionately got up in the fourth quarter and started yelling at the screen, and then keeled over. And it's interesting to recognize, we know that emotion can have some effect on our bodies, and here's an obviously dramatic kind of connection. Presumably, if the heart starts experiencing tachycardia, that this may have some adverse effect in a person who has a predisposition. Nonetheless, this now being some 30, not even wanting to know how many years later, there's still a lot of debate about the connection of emotion, psychiatric illness if you will, and heart disease. It's not an open and shut case at all. There's a still active question about whether people who have anxiety or depression or even general stress are at higher risk for having cardiovascular disease. Just as there's question about whether cardiovascular disease predisposes to emotional problems. Certainly intuitively it's true, and from my own experience it's certainly true, but if you actually look at the data, you find that there is moderately good evidence that there's some connection between being depressed and cardiovascular events, but not that much actual hard data of a connection between panic disorder, chronic anxiety, or even things like job stress and cardiovascular disease. Even the well-known supposed connection of type A personality, which I think most clinicians thought was pretty much a settled case, Friedman and Rosenman's discovery some 30 years ago, that there was a cluster of personality traits that had a clear association, they found, with heart disease. That even this connection between type A personality and cardiovascular disease is not necessarily a settled situation. And there are a number of studies that actually fail to establish this kind of connection. So, surprisingly, the intuitive sense that we all have may not actually be demonstrable in a research sense yet. Nonetheless, all my experience confirms that there's clearly some important connection between what our emotions are and what our cardiovascular status is. So I certainly, in my practice, look at a person's cardiovascular status whenever they have any kind of emotional illness to try to prophylactically, and sometimes in terms of specific treatment, treat both the depression and the heart disease. There is some interesting evidence that use of antidepressant medications may help to reduce the risk of heart disease in people who have depression. And that specifically includes SSRI, selective reuptake, serotonin reuptake inhibitors. The fact that that may well be true is interesting because that's not, at this point, generally considered to be a standard practice thanks Phil, to use antidepressant medications in a person who has heart disease but is not actively depressed at the time. In other words, the risk of getting depression or becoming depressed in a person who has heart disease is a significant risk factor, in some ways parallel to that of better known risk factors such as increased lipid levels and increased CRP levels. There are some other kind of interesting associations. It's not exactly clear why depression, for instance, should have a higher risk for provide a higher risk of cardiovascular disease. We don't know what that mechanism is. If we can establish that, that certainly will be a really major breakthrough. There's some tantalizing hints people who are depressed do tend to have a higher CRP, for instance, C-reactive protein. So there's probably some connection between depressed mood state and the inflammatory response. Exactly how that occurs or what function that may have served, we don't know. But it certainly does provide some kind of possible link for why depression may be a significant risk factor for heart disease.
Thanks briefly, John.
You mentioned that he's a psychiatrist.
Right, that's right. Yeah, Alan does, is a psychiatrist as well as an anti-aging doctor. But he tells me privately that he prefers his anti-aging patients like me who are, cheerful and healthy. So, so don't hesitate to get over there if you're looking for a good doctor. Now I want to introduce Bob Cathcart, who you already know very well. We are so fortunate to have him here. I mean, can you imagine? Here we have with us the world's foremost clinical authority on the treatment of viral disease, really, period. And of course, he does it by using megadoses of vitamin C. Since there are no other good treatments to speak of for viral disease as opposed to bacterial disease, this is a tremendously important thing, and it's a great shame that he's been doing it for 30 years and the world still really doesn't know about it, and the cultural adaptation hasn't taken place. But before he got into vitamin C, he was an orthopedic surgeon, as he mentioned, and he invented a prosthetic device, I think that's the right term, an artificial hip, which is very successful and made him quite comfortable, and which allowed him really to be the pioneering doctor that he has been for these last 30 years. I give you Bob Cathcart.
Thank you. I think I'll use this outline that Stan Field has graciously provided us. First of all, the cholesterol theory. Now, ever since I first heard about it, I've been talking about the cholesterol hoax. I don't really think that cholesterol is a major problem. I think that it's the oxidized LDL cholesterols that are the problem. And so that we try everything we can to keep the cholesterol from being oxidized. And guess what? Massive doses of vitamin C is an antioxidant, and that's one of the reasons why I think that most of us who take massive doses of ascorbic acid seem to do pretty well that way. Then there's the homocysteine theory. Now, homocysteine can be blocked by folic acid, or the manufacture of homocysteine in the body is blocked by folic acid. And I don't know why I came upon this, but I think since about 1975, anybody who came into the office with the slightest neurologic sign, and then it got to the point where practically if you had anything but a hangnail, you got what I call a triple B shot, which was 1 cc B12, 1 cc folic acid, and 1 cc B100, which is health food jargon for 100 milligrams of B1, B2, B3, B6. And the criteria was if the person felt better. So inadvertently, I guess I've been treating homocysteine all these years, and I really haven't had patients say, like for instance, Alzheimer's disease is thought to be somewhat related to homocysteine, and we just haven't had much trouble with that. Well, then the collagen theory here, of course, collagen, vitamin C. Vitamin C is necessary for the buildup of collagen. Now, one of the things that people are always asking me, what about the maintenance dose of vitamin C? Well, this depends upon what I call your gremlins. You guys here could kiss the wrong girl when they were 15 years old and get cytomegalovirus or Epstein-Barr virus or herpes 6 or something, and not get sick at the time, perhaps. And these are a burden the rest of the life. Plus, you've got the problems like Candida that comes on later on, especially in women. And we have food and chemical sensitivities. All of these things then create a drain on the body's vitamin C. So the amount of vitamin C you need to maintain a reducing redox potential in the body varies from person to person. It'd take a long time to go on that. But anyway, the next one, inflammation underlies all of these theories. Well, inflammation seems to be mediated by free radicals. And theoretically, if we get rid of all the free radicals, we get rid of all inflammation. Well, That's easier said than done, but there again, we've got the situation where massive doses of ascorbate force a reducing redox potential onto the tissues involved in the body. Now, one of the things I want to have it understand about this, our own free radical scavenging system in the body is rate limited. And they're a very complicated set of biochemical reactions that occur in the breakdown of glucose in the glycolysis and the citric acid that results in NADPH that reduces FAD to FADH2, that reduces oxidized glutathione to glutathione, which then reduces dehydroascorbate back to ascorbate. And so my point is that this is a rate-limited reaction. Now, what we're doing with the truly massive doses of vitamin C is throwing away the vitamin C for the electrons carried. That's, I think, perhaps the most important thing that I'm going to say here is the difference between the usual maintenance doses of vitamin C, which prevents the vitamin C from being broken up by these free radicals, or prevents these induced scurvy situations, is that with the massive doses, we are throwing away the vitamin C for the electrons carried. Remember, it's the electrons that neutralize the free radicals. Then finally, we have the effect of food on heart disease and mortality. Well, you know, everyone that I see, I work up for food and chemical sensitivities with the elimination diet and getting rid of their candida and so forth. Well, the thing is, you know, we make adrenaline and cortisone, and/or cortisone, to block the inflammations whenever we have an infectious disease or whenever we're under stress. And I want to tell you that I find most of the nice people that I see here who are not crazy and just maybe a garden variety, slight neurotic, but more or less normal, is their emotional problems I can trace back to the production of adrenaline. And very frequently, we can find that it's due to a food or chemical sensitivity. You know, there are hundreds of books written on psychosomatic medicine, but I want to talk about this somatopsychic. In other words, the body is driving the brain crazy. And so what we do is that when we find that a person has a food or chemical sensitivity, is we work that up and get rid of that. Now, the other thing is that when adrenaline oxidizes in the body, it becomes adrenochrome, which is one of the world's most depressive substances. So guess how we keep the adrenaline from oxidizing to adrenochrome? Need I say vitamin C in massive doses? Now, I want to give one example here of that you probably know that black people have a very high incidence of allergy to milk because they're lactase deficient. It turns out that only 2 African tribes keep cattle for milk, so it was possible to evolve in Africa without being able to digest milk. Now, you can't imagine a Dutch kid 500 years ago who was milk sensitive who would survive to reproduce. So this is the evolutionary process at work. Now, the other thing is young black men have a very high incidence of hypertension. Now, I have had 2 black men in the past few years come in with early hypertension. Both cases, I took them off of milk products, and within a week, their blood pressure was normal. But what's very interesting about this story is that at the 8-week follow-up visit, both of them said words to the effect that it makes no difference that my grandparents were slaves, I'm not angry all the time anymore. They had stopped making adrenaline. And so adrenaline causes blood pressure to go up. Remember, adrenaline causes vasodilatation of muscle cells, of muscle blood vessels, but vasoconstriction of everything else. So as we get older and we lose our muscle mass, our blood pressure goes up if we're making adrenaline. And so that's why I try to find out what all the inflammations are being caused by food sensitivities, chemical sensitivities, infections, and so forth. And then when we get rid of that, the early hypertensives almost invariably get over it, and they can get off all their medication. Now, if you've had essential hypertension, that is, if it's gone a long time, then maybe there's been some destruction to the kidneys, and this doesn't work so well, and so the blood pressure does have to be poisoned down. But other than that, anyway, those are my thoughts on
We've got Steve next. Steve is a resident genius, really. And and he happens to be a biochemist, so that's very helpful to have somebody like him around. In fact, over the years, I think I've learned more from him than anybody, possibly because I just kind of hang around him, hanging on every word and trying to write it down as fast as I can. Then if I don't understand it, I call him up, and he's so generous that I learned a whole lot, and many people have the same experience I do, so thank you, Steve. He also, in his youth, founded an important supplement company. Was it Diamond Research? Diamond Research. And he had for many years the best, the most in-depth, scientifically based newsletter in the health field that existed in the days before the internet, when we really were totally reliant on newsletters and things like that. Now, when the internet came along, that business was kind of mooted, and he went on to do other things, and doing some very exciting things right now that I can't tell you about that aren't really in the health field. But anyway, I give you Steve Fowkes.
Thank you. I guess I'd like to change the subject briefly and talk a little bit about politics and history, just because I think it's important for people to understand that the institutions that we have that deal with information and deal with health are fundamentally, at their core, biased. So, for example, when I first started getting into health, this was back in the late 60s and early 70s, the primary view of heart disease was it was caused by cholesterol. And I can remember coming back from college, sitting down at the dinner table, Christmas dinner, with my father, who was a cardiologist at the time, and saying, bald-faced, that I thought that dietary cholesterol had pretty much nothing to do with heart disease. And it was like, he was flabbergasted. Well, about 10 years later, he confided to me that he had looked into it and now agreed. So I'm not to say that the institutions necessarily learn, but individuals can learn. But the point is that there's a lot of opinions that are created by people in positions of authority. And the one thing that I've learned about academia is that people who are gifted often don't know how to handle criticism very well. And as a result of this, of not facing criticism until they're in high school or in college or in graduate school, that they don't have the same kinds of emotional strength and courage. And as a result, when they make a pronouncement about something, cholesterol causes heart disease, or homocysteine has nothing to do with heart disease, that this is not factual, this is based on their own insecurities. But this, because of the institution that they're embedded in, this becomes policy. And you get the weight of institutions like Harvard behind it, you get the American Heart Association behind it, you get the Surgeon General behind it, the food pyramid is designed a particular way to support it, and the result is massive disinformation. So, most people in this group have gone through this to some extent on various issues. If this is your first time here, well, there's nothing like jumping into the deep end of the pool without a life preserver. But I would point out a couple of things. One is, I don't think you should take anybody's word, without, asking questions about it, including this illustrious panel. Second, to understand anybody's bias really helps you qualify the information you hear. So even though I, for example, will tell you that fundamentally efficacy comes down to an empirical determination, I always want to know, how does it work? My whole focus on learning all this information about how metabolism works and how it affects disease is based on wanting to know mechanisms. A causes B, causes C. How is, for example, carbon dioxide and nitric oxide, which are both vasodilators, related to each other in terms of diseases? And that But just because I indulge that for my own reasons doesn't mean that you should necessarily believe that just because I have an explanation for how infection leads to depression doesn't mean that this is necessarily the answer to why these are connected to each other. So when Alan said, you know, this issue of how does heart disease result from depression, or you know, why, I can say, well, we know that inflammation produces an activation of certain kinds of enzymes in the body, one of which is called indolamine dioxygenase, which is an enzyme that circulates in the blood and destroys tryptophan. Tryptophan is a precursor for serotonin in the brain, which is an important neurotransmitter for happiness and tranquility and emotional stability and ability to handle stress and rage and football games. And so by having this inflammation activate this enzyme, the brain becomes depleted of serotonin, and this has psychiatric manifestations. But it also may be true the other way around. The body-psychic connection, where or the psycho-body connection, where the brain, by downregulating certain pathways, causes changes in the neuroendocrine system which affect glands like the thyroid gland or the adrenal glands, which are regulating cellular energy production. Cellular energy production is responsible for producing brain neurotransmitters, for reducing or re-reducing oxidized vitamin C and glutathiones, which depends the antioxidant defense system. It is involved in the synthesis of proteins, so healing and self-repair are dependent upon energy production. The heart, the pumping of the heart, the function of the immune system. So I can, you know, talk to you and mention all these particular mechanisms, but what I'm basically, I guess what I'm saying is that I see that there are two audiences out there. People who want to know why it happens a particular way, where if they don't understand that, the placebo response doesn't work for them. You know, it's all a matter of belief, and so if you have a rational-oriented view of the world, then you need a rational explanation in order for therapy to work, because that's in alignment with your mind. Whereas other people, you may be emotionally involved, or intuitively oriented, or, you know, spiritually oriented, where you may have a totally different kind of connection to information. And so, you know, for that, you may not at all appreciate a mechanistic explanation of what may be involved here. That's, I think, the real advantage of this particular group is that because we have a bunch of iconoclasts and radicals and pioneers who have questioned certain dogmas that have been put forth by institutions, that you have exposure to different points of view that you would not otherwise run across. So, for example, Ray Pete's coming into the next meeting. There isn't anybody who's more radical and more different than he is. So if you haven't ever heard of Ray Pete, haven't ever heard Ray Pete speak, I strongly encourage you to come here and hear him. The last thing that I'd like to mention had to do with an earlier comment about cardiovascular disease, and to point out that there are basically two different independent vasodilative systems in the human body. Nitric oxide, which is related to a lot of the recent focus on cardiovascular disease, which is the pervasive one, and then there's carbon dioxide, which is also a vasodilator, but tends to be more selective for the higher brain regions. So if you get very nervous, for example, then the adrenal hormones that are produced will cause your body to change its breathing pattern, which causes you to exhale a lot of carbon dioxide, and then your blood supply to your brain shuts down. So you can't remember what it is that you wanted to talk about. This is the basis of phobic attacks, stage fright, but that has minimum effect on your heart, which is driven by the nitric oxide system, which is entirely different. So even though vasodilation mechanisms can be common between both, there are differences in how much each system relies upon different dilative systems, so therefore they can be on some levels very much independent of each other. So just because we see a correlation doesn't mean it's always going to be there, and a lot of mechanisms are like that. We may see, be able to describe to you 20 mechanisms involved in heart disease. Vitamin C and its effects on collagen, effects on infections. We mentioned viruses, but there are potentially parasites and bacteria that we don't even know exist. In other words, we don't even have a way to measure them. And these kinds of processes may be involved in a disease like heart disease where, all you can see is the manifestation of the disease. So it's good to know what you know and what you can know, but it's also wise to understand the limits of your knowledge or know your own ignorance. And that's one thing that I've learned in all these years, is that for every time I answer a question, I can now come up with 2 more questions. Therefore, my ignorance expands faster than my knowledge does.
Thanks, Steve. Okay, last panelist is Phil Miller, who practices medicine, anti-aging medicine in Los Gatos, has the Longevity Institute, and is fast becoming one of the nation's best-known anti-aging physicians because he just wrote this terrific book, which you've heard me recommend it before. This is a book that he wrote with the Life Extension Foundation, and it's really good. It's a terrific summary of all kinds of things, including some stuff on artery disease, cardiovascular disease. I asked him to bring more copies, and we've got some copies over here that will sell you for $25, isn't it? Right. And this is a hardcover book. It's well worth it. I think everybody should have it. I give you Phil Miller.
Thanks, Phil. Well, like Alan, I came not knowing what this was going to be about. But let me make a comment about what Alan said. Having watched the 49ers since the early 50s, the 49ers will do that to you. The 49ers will give you a heart attack. And they kind of go in waves, and we're back to them giving us heart attacks again. I have a background in emergency medicine and urgent care medicine. And some of the things that I've been looking at in the last, couple of years is that, my real love is, and my charter is, what I do now, is anti-aging medicine. And I do now what I really wanted to do when I was a medical student, and I remember even my closest friends who were all iconoclasts at the time said, well, that's pretty fanciful, which was, I wanted to spend a lot of time with my patients and see very few patients. Well, I did emergency medicine, I did urgent care medicine, and there were times when I was seeing literally 80 or 90 patients a day by myself. Urgent care clinics where I'd see 160 people a day with 2 other providers. So I've done that. That's not what I do now. What I do now is I really see people more in depth. There's a lot more interaction. And the reason I'm telling you this is because the other thing that I've been seeing in the last year or two, just in terms of, I guess, my own comfort level and where you get when you get toward beyond 30 years of medical practice, is that I have had a lot of experience in cardiology at that really traumatic level, just heart attacks, strokes. So I've done all of that. And I've seen the cardiologists, and I know what the cardiologists do, and speaking to what Steve said, what you find is in medicine and in science, there's more dogma than there is science. That physicians, when they call themselves scientists, are not really scientists, they're just following a particular dogma. And the dogma that's been going around for 30 years is, well, we know that cholesterol causes heart disease. A theory that even I didn't believe when it first came out. And everybody told me I was really an idiot because everybody knew that cholesterol causes heart disease. Framingham studies showed that half of the people who get heart attacks have normal cholesterols. So what we're doing is we're now looking at a whole variety of other factors. And I presented that to this group here a couple of months ago. So what I've really been looking at is how, you know, I can provide a model, and hopefully, you know, what we'd like to see is we'd like to see more people doing this, which is people who really have experience, I mean really solid experience in good clinical medicine, treating the really heavy-duty types of cardiac events, who then can bring to a new audience what we call integrative medicine, complementary medicine. I mean, there's all these names for it, but what I always call it is basically bringing to bear a larger toolbox. And so what I tell people somewhat unabashedly is that, you know, I'll match myself against any cardiologist in town, because I'll do a better workup, I'll do a more thorough workup, I'll do the things that the cardiologists do, but then at the end, instead of offering you agents that just mark time and temporize, what are things that we can do that we can rejuvenate, rehabilitate, and actually bring back function? And that's what we're looking for, is how can we restore function, cardiac function? And so, you know, in anti-aging medicine, what we're always looking for is cognitive function, physical function, sexual function, spiritual function. It's the whole gamut. So in cardiology, what can we bring to bear that brings you a more global and a more far-reaching and comprehensive approach? And that's what I think I give my people. So I just wanted to speak to a couple of things. I wanted to bring out a couple of threads that I've really been thinking a lot about just in the last couple of years, some of which I've spoken to in the past. But I want to bring these up again because these are the threads that you're going to hear you know, in the next couple of years. I had this discussion with my local VAP representative. That's one of the blood panels that's sort of an alternative to the Berkeley Heart Panel, where we're really looking at all the various LDL isoforms and the HDL and the lipoprotein A and homocysteine and pattern A and pattern B and a whole variety of ways of dissecting out risk factors. And in some ways, this sort of becomes almost, in some ways, we may be getting to reductio ad absurdum, where what is the risk factor? And what is the risk factor? There is no the risk factor. So we look at a whole host of factors that may be risk factors for you. So what I've been looking at is, and what he talked to me about, he said, well, you know, the LDL mafia wants you to believe that statins are the answer. And even some of the best cardiologists in the country, who are the most nutritionally oriented, when push comes to shove, will still tell you that statins are the way to go. And so what we're seeing now is we're seeing, statins to me is a triumph of marketing. And statins really are kind of morphing, instead of just saying, well, we're reducing LDL because, you know, that's the bad thing. Now it's like, well, we're finding out they're really anti-inflammatory, and they're really good antioxidants. And so I'm thinking, well, that's good. I think we've got better ones than that. I think the group here would agree with that. What you're going to see, though, is this. Here's the prediction. We don't have any drugs right now to raise HDL. HDL is the scavenger. HDL is what clears cholesterol from the heart. And incidentally, I've said this over and over again, cholesterol is not the enemy. Cholesterol is a repair mechanism. It's a patching mechanism. It's the ability of the body to try to repair something that just kind of gets out of control. So HDL carries cholesterol away from the heart, LDL carries it to the heart. Well, there are phase 3 trials of HDL raising drugs that are really pretty significant. And I think you're going to see, in the next few years, we're going to see this gradual and then very determined shift from this focus on lowering LDL to raising HDL. And so I've begun to see that the ratio of the LDL to HDL, which I never quite understood before, probably is a better measure instead of the traditional cholesterol to HDL that you're familiar with. That's the cardiovascular risk that everybody talks about. The real one that probably is going to be better is the LDL to HDL. Because there are women, maybe in this audience, but women I've seen with HDLs of 115, 120. I don't care what their LDL is. They've got such good scavenging mechanisms that you look at their LDL to HDL ratio and it's phenomenal. So they could have a total cholesterol of 240, but their HDL is so high, doesn't matter. Now, let me tell you a couple of other threads here too. Going back to the talk that we had, it was either last month or the month before on nanokinases, it was something that was really interesting that he mentioned. And I talked to Ralph about this on the way back. And I really began to think about this, and this is one of the big things I want to leave you with tonight. We're really good, especially in this audience, and in my practice, and each practice here, we're really good at focusing in on cardiovascular risk, preventing the big one, the heart attack. But luckily, most of my patients kind of bypass that one. And so what I'm becoming more interested in is, what do we do when we go beyond the MI, the heart attack? And what I'm becoming more and more interested in, I guess as I mature a bit and look at 60, a little bit more realistically, is I'm focusing in on valvular heart disease, something you don't hear much about. And so what really occurred to me, was really interesting, is when Ralph was talking to you about nanokinase, one of the things he was talking to you is something that I've been thinking about a lot in the last few years, which is called rheology. And the simple-minded analogy that I make when I use the term rheology, which is really a physical flow, and there's laminar flow, and there's a whole bunch of stuff that I wish I really knew the fourth inverse power ratios of. But basically, rheology is simply, do you have 10-weight blood, or do you have 50-weight blood? Is your blood sludgy, or is your blood real thin? Are your blood cells coated with Teflon and don't stick? Do they not clump together? And that's how you do, that's how you're preventing cardiovascular events. So the rheology is blood flow. But what Ralph mentioned, the last thing I was trying to figure out was, in the outflow tract of the heart, the greatest jet, the greatest flow is going right past the aortic valve. And this is what I'm beginning to see in guys, not as much as in women, but this is what I'm beginning to see in guys who are in their mid-50s, late 50s, and into their 70s. You've bypassed all the ones that you worried about. Now you're at risk for valvular disease. And you're at risk for valvular disease, one, because we begin to look at calcium flux from bone to tissue, and we begin to look at rheology and the hemodynamics of that blood flow going past the aortic valve. So the aortic valve is taking the brunt of all of it. Somehow the tissue calcification, I think, seems to be there, and it's probably partly because of the laminar trauma is greatest, where that jet from the left ventricle is forcing blood. So it's the aortic valve that I'm becoming most concerned about. Now, okay, so why am I interested in this? Let me leave you with this. One of my patients, who's been seeing me for years, and he kind of has one foot in anti-aging medicine, the other foot in traditional medicine, developed aortic disease. I made the diagnosis. One of his cardiologists wouldn't. He finally went to see another cardiologist. He finally said, yes, you do have aortic disease. He's been on Coumadin. I told him Coumadin was going to make this worse. At some point, he then goes to Stanford, gets a second opinion. She says, you got time, don't worry about it, don't worry about all this. He comes back to me, he says, what do you think? And I said, Bill, I don't usually recommend this. You need an operation, and you need it now because of your aortic valve. He went in for surgery last week. He left me a message. He said, if I hadn't listened to you, I'd be dead. And I just wanted to thank you. So that's a pretty powerful message. I'm beginning to look at valvular disease, we're looking at rheology, we're looking at calcium flow. If you begin to study and look at all of these, it opens up new vistas. And that's what this is really all about, is how do we open up new vistas? Because if there's one thing that should be common to all of us here, is that we're seekers. And seekers open up new questions. That's one answer. Thank you.
Okay, now I noticed that it's 8:45, so I think let's take a break right now. And we'll go get Time magazine to frame their ad in an article. Can you believe it?
Anybody remember Prozac?
When Prozac was introduced, this was right after the FDA banned tryptophan. So the cover of Time magazine had a Prozac capsule floating on it right after the FDA banned tryptophan, and since Prozac and tryptophan compete for the same general effect in the brain, or at least theoretically, that was a very odd coincidence.
Right. Okay, now the then Life Extension magazine, which just arrived a couple days ago. This is the, I think maybe the October issue actually. Yeah, it's October 2005. You know, they always send it out to members early. So here's the October 2005 Life Extension magazine. Doctors ignore real cause of atherosclerosis. Now, I love Life Extension magazine, and this article is tremendous. In fact, they have 2 articles on this subject. They have the article itself, which isn't really as good as what Bill Fallone wrote, as an extended kind of article editorial to open the magazine. Bill Fallone, is it Falloon? Is that it? Falloon is kind of the editor or something. He's the head publisher. He's the head, one of the head guys over there. Head honcho. And he wrote a terrific essay, really good essay, which is better than the article, I think. And in his essay, he had this page which I copied and passed out. And I thought his presentation of the real causes of atherosclerosis, or in other words, of artery disease, is really elegant. So I just wanted to call your attention to it. I don't think anybody in the panel would disagree with this. Now, but he kind of puts it in a new way. And he says, down here in the middle, the most important term that you may ever learn in your life is endothelial dysfunction. and
3 times really fast.
Endothelial dysfunction. It is the pathological condition that causes more Americans to suffer disability and death than any other phenomenon. Now, what is endothelial dysfunction? The linings of the arteries, and maybe, I guess maybe the veins too, but I mostly think of arteries, they're lined with a very thin membrane. I think it's only like 1 cell thick. And it's described by John Cook at Stanford as the silver lining. You take it, it's like a sheet, just a very thin, transparent, almost sheet, that lines your arteries and separates the blood from the smooth muscles. The smooth muscles, of course, are working, contracting, and dilating as necessary to keep you prepared and adapted to whatever you're facing. When that thin layer of tissue, which is called the endothelium, is damaged, and it can be damaged in a number of ways, then the whole process begins of laying down the oxidized cholesterol, the macrophages and the foam cells grow, and then the calcium comes and starts to get involved, and then you get hardening of the arteries, and the whole thing happens. And the interesting thing about endothelial dysfunction, it can happen in all these different ways. One way it can happen is just by getting old. Everything kind of, gets thinner and so forth. And another way is homocysteine. And another way is just the sheer factor of the blood rushing along and finally, having a sudden wear and tear, and your body's not repairing itself as well as it should. All these different mechanisms can cause endothelial dysfunction. Well, the interesting thing is that there are ways you can keep your endothelium strong, and you can rebuild it. And one of them is arginine, which we talked about before. And John Cook has written this wonderful book about arginine. He's not the first guy to come up with it, but he's, I think, the first guy in the establishment to come up with it. John Cook at Stanford. So I wanted to call your attention to that. And a lot of the things that we've been talking about can be put in the framework of endothelial dysfunction, the various ways it can happen, and what you can do to prevent that. So now, with that much said, let me just ask the panel if anybody wants to jump in, and then we'll open up for questions.
This area of endothelial dysfunction, actually, believe it or not, some of the far-thinking cardiologists actually have been thinking about this for about the last 5 years. But what it comes down to is this. I think, let me put it in a different perspective. Endothelial dysfunction is like that first barrier. It's that thin layer of your vessels, your coronary arteries. And the really interesting thing, and I think another frontier is going to be when we really discover not just nitric oxide and arginine, which we're beginning to really look at in terms of what the power of that is, but I think we're going to begin to discover a whole rich plexus of local hormonal control of the heart. That there's going to be more than just one. It's not going to be just nitric oxide, which then leads to endothelial relaxation factor, which is all mediated by arginine and nitric oxide. So there's that whole discussion that we're hearing more about. But I think we're going to hear more and more in terms of local hormonal control of the heart. Various agents, whether they're neurotransmitters or hormones, and their effect. And so when we look at atherosclerosis and arteriosclerosis and hardening of the arteries, really what we're really looking at is the impermeability of all these local hormones to exert their force. So what happens is you have to clean that up, repair it, and allow those hormonal influence to reassert themselves. That's why, again, I'm really against coronary artery bypass, even though I know it saves lives. But what you're doing with coronary artery bypass, you're taking veins which are stupid vessels and replacing them from arteries which are smart vessels. Veins are capacitance vessels. They just hold blood. Arteries are smart vessels. And I don't think, I'm not convinced that you can arterialize venous vessels. And the really stupid thing that's being done with increasing frequency are stents. This is really a dumb idea, putting these little cages. Kind of reminds me of the old Chinese puzzles, you know, we used to go to Chinatown for. These finger puzzles. But they're putting these little cages in there, so all we're doing is just holding the artery open, okay? Which basically just keeps increasing the arterial damage with a foreign body. So what they have to do is say, oh, now we've got smart stents. But we've got ones that secrete little hormones and other little things. So we're trying to synthetically try to do what really we should be doing, which is how do we rejuvenate and repair these vessels with all these artificial devices.
Speaking of hormones, you know, brings up testosterone, which is, you know, at puberty, how men gain strength and so forth and so on. And it builds up muscle, and the most important muscle of the body is the heart. But I wanted to talk about nanobacteria. This is a controversial thing, I say. I think if you do a Google search for nanobacteria, you come on down on this nanolabs, and they have all sorts of articles in there. And there's one by a Stanford professor who says that has found nanobacteria in every oxalate kidney stone. And as a matter of fact, other articles say that whenever there is any arteriosclerosis, any calcium deposit in the body that's not supposed to be there, like not bone, but calcific tendinitis and so forth, there's always nanobacteria that they can culture out of that. And so like with aortic disease, if you've got calcium in the aorta valve, there may be an infection there of nanobacteria. Well, where this got me interested in is how come vitamin C does not cause kidney stones? And you know, when Linus Pauling wrote his book, everybody said that, or the doctor said that vitamin C would cause kidney stones. Well, because some of the vitamin C breaks down as oxalic acid, and that ought to combine with calcium and cause calcium oxalate kidney stones. Now, for instance, my urine oxalic acid is 3 times normal, but no kidney stones. And we can do that with any of our patients taking a large dose of vitamin C. They have enormous oxalic acid in their urine. Well, the thing is, I think we not only have the most expensive urine in town, we have the cleanest urine in town. Actually, there are people who, some of the avant-garde urologists are using massive doses of C to keep the catheters from getting infected and so forth. So I think this is the reason why that we may be protecting ourselves from nanobacteria, in that when we have these high levels of vitamin C circulating in the blood, it may be that that's helping to kill the nanobacteria in the blood that seems to be at in every calcium deposit. Now, the other thing I want to talk about is calcium and magnesium, intracellular ionic calcium, which brings up the subject of chelation therapy, which nobody's talked about here yet. But the old-style chelation therapy, which I do, is the magnesium EDTA intravenously. Now, there are new forms of oral chelation, and sometimes using calcium EDTA, and I think these are fine for people who have lead, cadmium, mercury toxicity and so forth, to get those things out. But one of the things that happens as we get older, the intracellular ionic calcium goes up and the magnesium goes down. Now, calcium is almost a mitochondrial poison. About 3/4 of the coenzymes in the mitochondria are magnesium, and calcium competes with magnesium. So that when we chelate with magnesium EDTA, the EDTA has a greater affinity for calcium than it does magnesium, and so it drops the magnesium right inside the mitochondria where it's needed and takes out the calcium with it. So I think this is one of the great causes. Of course, with our chelation therapy, there was an article in one of the major journals that had EDTA chelation with large doses of vitamin C, 2 grams, and I always use 60 grams, so there's a little difference. And they came to the conclusion that EDTA chelation was actually beneficial, but vitamin C was not. But anyway, that's the way these studies go.
I'd like to spend a little bit of time talking about collagen, because collagen is a major structural protein of the human body. I mean, it's not just the vascular wall and endothelium that uses calcium, and the muscles that use calcium, but the bones and the tendons and the ligaments and the brain. If you destroy the calcium in the brain, your brain turns into collagen. Yes, turns into liquid. This is a major 30% of all the protein in your body is collagen, and collagen requires vitamin C for it to mature properly. Collagen is an extracellular protein. I mean, it's not just produced in the cell, but it's produced in the cell in one form, it's excreted from the cell, it's then modified into another form, and then modified into another form, laid down in a matrix, and then aged in particular ways. It's a very complicated process involving multiple nutrients. So if you have a problem with your calcium, or excuse me, with your collagen, your healing process, your healing capacity is going to be compromised. And that includes the endothelial lining of your vascular system. This is the basis of Matthias Rath's vitamin C and lysine with or without proline and glycine therapy for dealing with cardiovascular disease. And I think that this is also one of the benefits of megadose vitamin C, is that vitamin C deficiency in humans and guinea pigs and selected other species causes a weakness in the issue of maintenance of collagen. So all kinds of vascular accidents can happen from collagen deficiencies, like, for example, aneurysms, where you have a weakness in the blood vessel wall, and the body produces collagenase enzymes at that site of irritation, because the collagen that's there, it's not mature properly. It looks to the body like it's malfunctioning, like it's old, it's time to be replaced. The body goes in and dissolves it, and then lays down new collagen, which is defective. The body dissolves it with even more enzymes, tries to lay down new collagen, and you end up with this destructive cycle that causes a complete deterioration in the infrastructure of the vascular wall. Similar things are happening with plaque accumulation and calcification of blood vessel walls. So it's very important to understand that collagen is the basic, infrastructure of body integrity, and that one has to feed this process. And so I would say for anybody who's taking vitamin C, who's treating, in a sense, a collagen deficiency condition, that they not only rely upon vitamin C, but consider the 3 amino acids that are involved in making collagen: proline, glycine, and lysine. And proline has to be made in your body, and so you don't really get it from your diet unless you take it as a supplement. This could be an important factor that for people to include proline, and that one include bioflavonoids, which assist in the function of vitamin C to age the collagen, and that one not have an iron deficiency, copper deficiency, or silica deficiency. That all of those be adequate to the challenge. And so those are the necessary factors involved in collagen maturation. Now, the additional element that I would bring into this has to do with hormone profiles that are associated with aging. It's one thing to say, well, aging causes this effect, but all of us, mechanistic freaks want to know, well, why does this happen? And there's hormone shifts that take place in aging. Testosterone is certainly one, but progesterone serves a very similar function. Testosterone and progesterone are both hormones that regulate protein synthesis. So the amount of collagen that your body makes is dependent upon those hormones. So if you have a deficiency of testosterone or progesterone, your ability to make collagen is going to be compromised. Also, if you have a zinc deficiency, that will also impair it independently. But
one thing when we start talking about supplementing with amino acids and this nitric oxide thing of arginine, now remember, you people who might have a shingles or any other herpetic type of lesion, it might be aggravated by this. Now remember, massive doses of lysine, totally non-toxic, beats the heck out of all these drugs that they use for herpes. And so I have found that if a person has chronic herpes, if you give them lysine in massive, maybe 500 milligrams, maybe 6, 8, 10 of them a day for a while, the herpes clears right up. And as a matter of fact, if you keep them on relatively high maintenance doses, you can add arginine to this without causing a herpes attack. The reason why I bring this up is because the orthodoxy, the people who originally did these little studies on little doses of lysine on herpes said the reason why it worked was that it blocked the formation of the viral DNA by blocking the effect of arginine. Lysine blocks arginine. Well, I don't know about that because I've had a lot of patients on lysine for long periods of time, and none of them show any excessive signs of aging, which if you were blocking human DNA, you would think people would be aging more. So you don't have to worry about that. But remember, if you have a herpes infection, be careful of arginine without taking huge doses of lysine.
Yeah, Phil, taking off on your comments about Lipitor, I wanted to remind the group that that there are probably people in this audience who are taking statins. And I'm not necessarily suggesting, and I don't imagine any of the panel would say automatically not to be on the statins, but for God's sakes, if you're going to take statins, please supplement with generous amounts of CoQ10. I think this is one of the scandals. Imagine that the Time ad, for all its thousands of words, doesn't say a word about CoQ10 needing to be supplemented when any of the statins are taken. When I see patients in my practice, many of whom are on a statin, I often don't want to tangle with their cardiologist or primary care doc and have them get off of the statin, but at the very least I try to persuade them to take at least 150 milligrams of CoQ10 with meals, because the statins all block the formation of CoQ10, which is essential in our energy production system. As an aside...
Is aspirin one of the statins?
No. As an aside, this is not new information that I'm putting out, as many of you know. But a number of years ago, when my uncle, who was a dermatologist and vice president of Revlon and considered himself a scientist and relatively open-minded, had cardiac bypass surgery. I begged him to please take CoQ10. And he scoffed at it, thinking this was just his maverick nephew had some other crazy idea. So I sent him some articles on it, and I sent him a case of CoQ10. and about a month later, I got back a box with the entire supply of CoQ10 and about 20 articles and references that showed that he thought that CoQ10 was not proven to have any benefit. He died about 2 months later. It shows the intransigence, as Steve was saying, of the medical establishment, even to the...
When their own life is on.
Even when their life is on the line. It's just extraordinary. And this is why we're up against the hardening of the calcification of the cerebral arteries.
I do want to say, though, that I
Must be
see
medical
several
professionals.
physicians who come in for chelation therapy who never refer me patients.
They want to admit that they're doing it.
That's a very important point. Okay, now we can go to questions. I'm going to run around with the mic here. Let me get this gentleman, Bill, and then I'll come to you. Okay.
Recently, we heard about this Peruvian drug called maca. Now, maca is supposed to balance hormones by providing both the male and the female hormone, and the body is supposed to use it in a way that it needs it best. Does maca have any influence or therapy in regard to cardiovascular disease?
I'm not trying to answer your question directly, but just to provide a degree of skepticism and caution in terms of approaching commercial literature. For years, people said that estrogens were sources for DHEA in the human body without any evidence that there's any conversion whatsoever. This, massive amounts of promotion, even doctors were caught up in that belief that you could take these phytohormones and they would be converted into human hormones. So if you send me some literature, I'll take a look at it and see if there's some basis for it. But on the whole, I'd be skeptical because I've run across this kind of claim before and it's never proven out. The only hormones that do convert into human hormones are the natural precursors that most of us probably know about, like cholesterol, pregnenolone, progesterone, DHEA, androstenedione, androstenediol, those kinds of hormones, which are natural compounds. Those are converted.
Well, not to disagree with my esteemed friend Stephen, I'm a really big proponent of maca. Maca has been studied very loosely by the Prostate Awareness Foundation as an alternative to testosterone. And I will agree with Steve in the regards that I'm not so sure that maca is really a replacement for testosterone or hormonal as much as, and I'm going to be somewhat unscientific here, I think it is what I call Peruvian ginseng. And one of the things that I've seen about ginseng, whether it's Siberian ginseng, which is not really ginseng, whether it's Korean ginseng, which is the most potent, Chinese ginseng, or American ginseng, is that when you try to read about these, that there's scant amount of really known biochemistry, and yet these are compounds that have effect. I use them in my patients for adrenal function. And so there are times when the biochemical literature probably is not as replete as we'd like it to be, and we have to then go toward empirical evidence and empirical results. The one thing that I can tell you about maca is I use root. Whenever I use herbs, I use whole root. I don't use caps, I use root. So personally, I take 2 tablespoons of maca every day. And if you look at the jar, the big thing that maca has in it, apart from all the stuff that you're hearing about, huge amount of potassium. And potassium, to me, virtually everybody who sees me is low on potassium. And potassium is a major stabilizer of arrhythmias. So a side thing is, just for the potassium alone, I think maca is a great thing. But I think it does other things too.
Hi. I've heard a lot about the micronutrients related to heart disease, but I don't think I've heard much this evening about the macronutrients. In my research, through the ecologic approach, I've studied them in the past, and after studying Alzheimer's disease, which identified total energy, total calories, and total fat as big risk factors, and fish or fish oil and cereals as risk reduction factors, I then went on to study heart disease, and I made the discovery that while for men and for older women, animal fat appeared to be the big risk factor, for women below the age of 60, sugar was the big risk factor in this multi-country approach. And so I hired the National Press Club office. I went up there to D.C. to give a press conference, and not only did the president of the American Sugar Association show up and made on parade, but also Ron Krauss from Berkeley, who is the head of the Nutrition Committee for the American Heart Association, issued a press release saying that I was all wet and giving wrong dietary advice to the American public. Well, it turns out the American Heart Association in the 1960s or 70s followed Ansel Keys down the path of animal fat being the big risk factor of heart disease. And so they started in the 80s or 90s giving the American Heart Association seal of approval for low-fat foods. Never mind that they replaced the fat with sugar. And so here I was getting into their money-making scheme without realizing it. And I think later even Ron Krauss had to agree that triglycerides were a risk factor for heart disease, and that lipids didn't explain, dietary lipids didn't explain the triglycerides. What else do I want to say? That diabetes, of course, is a risk factor for heart disease, and that is related to, I think, both sugar and obesity, and maybe the panelists can discuss that a little bit more. In my own case, I think that as I've added more nuts to my diet, my HDL has gone up quite a bit. I think nuts are a good source of HDL and cheaper than drugs, and I think they've been shown to have heart beneficial effects. Of course, vegetables and fruits with antioxidants are good as well. So that's some consideration.
That's Bill Grant, PhD, who's doing a lot of great independent research on vitamin D. You've heard from him many times. Thanks, Bill. Steve?
Yes, I was wondering about the panel answering some questions about diet is the main thing to reduce cardiovascular disease. I remember Pritikin, he's the first one to use a diet years ago in Los Angeles, and he just reduced the fat to like 10% of his diet, and he had really bad atherosclerosis. And when he died, they did an autopsy, and the atherosclerosis went away. And also Dean Ornish, he showed studies through diet, low fat content. He reversed atherosclerosis from his clinical studies. So it seems like they're eating more vegetables and fruits. And I talked to this Furman, who wrote a book on diet, stuff like that, and reducing heart disease and other stuff. And he said, I asked him about vitamin K. He said, you don't take supplements of vitamin K, because if you eat enough green vegetables, you get enough vitamin K from vegetables. And also, I'm not, in vitamin C, I hate to mention this, they say just eat the vegetables and the fruits, and you get enough vitamin C from that. And you don't have to take these big supplements. So I just wondered what the Mediterranean diet and the DASH diet is big on vegetables and fruits, and they seem to have lower heart disease. Does the panel have any recommendations along with diet?
Start with this end. Yeah, I do. But it's not like I can make a single recommendation for everybody. I'm of the opinion that people are as different in metabolism as they are in appearance and capabilities, and that it's important to operate with a diet that's consistent with your metabolism. And so I believe that some people who follow a low-fat diet will die from acute heart disease directly as a result of eating that kind of diet, and that other people will thrive on that kind of diet. in terms of going back to the issue of, let's say, animal fat and sugar, I think that it's important to understand that there is a basic aging mechanism involving sugar and fat. That when we are a fetus, we are 100% glucose driven in our energy metabolism. And then when we're born, that starts to drop as our tissues differentiate from a stem cell into a heart cell or a muscle cell. There's a reduction in sugar consumption by that cell, which triggers the differentiation process. And that as we get older and older and older, our metabolism shifts from carbohydrate-driven energy systems to fat-driven energy systems. And that all of the advice that we're given and the dominant trends in Western society is not to allow that process to take place. And we see that in several ways. Like sugar, obviously. Sugar everywhere. The more carbohydrate, including fruit, that you eat, the more you're forcing your body to burn carbohydrate and shutting down your fat mechanisms. Whenever your body has a choice, it will burn carbos before it burns fat. So if you drink alcohol, it shuts down your fat metabolism. You eat fruit, it shuts down your fat metabolism. High triglycerides are a sign of an inability to burn fat. So this is not necessarily indicating that fat is necessarily bad, but that not being able to handle fat in a healthy way is bad. So I think this is a mistake to conclude that when you see high triglycerides, this means that somehow eating animal products is inherently unhealthy. Likewise, with sugar, sugar leads to insulin resistance. That's well connected to heart disease risk. All kinds of neurological problems and health problems as a consequence of insulin resistance. And the insulin resistance can be relatively selective in early phases and only affect the carbohydrate side of things and leave the fat metabolic systems fairly intact. But in our modern society, not only were we over-consuming glucose to drive this insulin-resistant process, we're consuming hydrogenated fats that are suppressing the fat-burning systems. So we're inducing compromised carbohydrate metabolism and compromised fat-burning metabolism at the same time, and we wonder why we have heart disease, and we wonder why we have depression, and we wonder why we have symptoms of aging. It's very important for the human body to have energy. Fundamentally, everything is driven by energy. And so, ideally, whatever diet works to open up your metabolic systems and allow you to have a robust and healthy energy metabolism is probably in alignment with the overall purpose of health and well-being. And that may be, in some people, a high vegetarian diet. In other people, it may be the Paleolithic diet. But certainly, it doesn't include refined carbohydrates in high amounts and refined fats, the kinds of things that are stripped. Now, one of the things that I've learned about science is you can always design a scientific experiment to prove a preconceived conclusion. It's very easy to do. And there's all kinds of fraud that have been perpetrated on people. How many of you remember the vitamin C causes DNA damage report that came out like 3 years ago or something like that? So there are 4 kinds of DNA damage, and they measured only 2, and only one of which is actually enhanced by vitamin C. All the other 3 are decreased by vitamin C. But because they chose to focus on the one that was increased, they could say enhanced DNA damage, despite the fact that vitamin C is used in the animal husbandry industry as a sperm preservative pretty much universally. So that's an example of that kind of manipulation of research. When I was in high school, my father, as a cardiologist, was in that cholesterol and vegetable oil thing and put us all on vegetable oil. We had corn oil, was our families, vegetable. We fried tortillas in corn oil, all this kind of stuff. We now know that to be massively atherogenic. You know, if you wanted to design the worst program that you could in terms of cardiovascular health, you know, corn oil, you put it on the list. But at the time, this was being promoted because all the research was being supported by the domestic oil industry. Likewise, how many of you remember the thing about saturated fats and coconut oil that caused the popcorn industry to switch from popcorn made in movie theaters from coconut oil? This is all this research is funded by American interests, where there's no coconut oil produced in the United States. And there are plenty of other oils that they want to sell, so they design studies to meet those kinds of conclusions. So, again, this issue of I know people who've been on the Pritikin diet and have thrived with it, and other people where it's almost killed them. I've known people who've been vegetarians where they feel really great for the first 6 months, and then all kinds of things start to happen to them. It's not until they go back to eating meat that they become healthy again. So I think that all of these considerations need to be assessed on an individual basis based on your experience, and that, you know, it's not something that you should necessarily take somebody else's advice. Just because somebody else has a good experience on a particular diet doesn't mean that you will.
Is there a difference between grain-fed beef fat and grass-fed beef fat? And they don't. Every time you talk about it, I read magazines. They always talk about fat, but there's a vastly different kind of fat. Okay, and I listened to the guy on Fowkes talk one day, and he was talking about beef fat, and then I said grain versus grass. Grass is natural, grain isn't.
That's true. Basically, when you're eating grain-fed meat, you're eating meat from diabetic animals.
Let me kind of go back to a couple of comments you had made. You know, there was this progression with Pritikin. One of the things that Pritikin did that was really revolutionary was brought to the idea to the public and then to the scientific community that coronary artery disease could be regressible. I mean, that's what he brought. That's his great contribution. And so whether the diet was right or wrong, we have to look at it in the historical perspective of that was considered heretical prior to Pritikin, that you could regress coronary artery disease. That's been well proven in large studies. The problem with Pritikin was that Pritikin didn't understand the value of oils. So his whole thing was low fat, but then he didn't understand the really incredibly important aspect of essential fatty acids. And so all of his people started developing dermatitis and all sorts of problems with their skin because it was so low fat that it was, all fat was out. Then, you know, my mentor, Whitaker, came along and he kind of improved on that, but then Julian also was a big advocate of lots of, you know, grains, and he was wrong. And then we progressed to Atkins and to Sears, and I'm of the persuasion that all of us are not getting enough protein. And so I'm really big on people getting enough protein and keeping the fats and the carbohydrates down. And I don't go by percentages, because you know what it is. It's simple that you can just eliminate bread, you can eliminate ice cream,
Potatoes.
and potatoes, and rice. So there's certain things you can eliminate. One of the things that every one of you, and I hate to say this kind of stuff, because you hear this all the time. Well, go to your doctor and ask him to do X, Y, or Z. And the doc is either commenting and saying, oh, sure, I'll do that, or don't you tell me what to do. But one of the things, there are a number of things that I do that should be done, but if there were like 2 things that I could say are not done routinely that should be done, one of them is a fasting insulin. All of you should have a fasting insulin at some time. Because if it's 5, you're home. If it's 10, it's elevated. If it's 20 or 30, you got big problems. And that's how you begin to see whether you're at risk for insulin resistance. Because if your insulin is 5 at fasting, you don't have insulin resistance. So there's a way of pretty quickly measuring this. The other one is, and the one almost everybody in this room should know, is you should be getting lipoproteinase. And now there's a new one, the lipoprotein XYZ. There's another one that just came out. But lipoprotein A is a really big one, and the reason why I'm big on it, because I personally think it's a contributor to problems in the brain. And again, we concentrate on people who are after 60 are more worried about what's going on in your brain as much as your heart. So those two things, fasting insulins and the lipoprotein A, because there's no push, there's no drugs for these things, although there is drugs for insulin resistance. But it's not part of the usual routine that's being done.
On the fasting insulin, that could be zero, can it?
No.
No?
Okay, by the way, for those of you who haven't seen the term yet, it's lipoprotein A. Get that? Lipoprotein A. Okay, now I want to stop at 9:45, so let's have just like one or two more questions here. Who's got a question on this side?
Okay, actually, I wanted to just do a little audience survey here. Raise your hand if you've used vitamin C and it's effectively knocked out a virus or cold in a day or so. Okay. And keep it up if you've done it repeatedly. If you've repeatedly used it more than once. Okay, yeah, so we probably have, I don't know, about a third of the audience supporting the vitamin C.
It seems to me that it's had better, more reliable success if I also add in lysine and other goodies to fill those up.
Okay.
Well, what about the opposite of that? How many people have tried it and it didn't work?
Okay, yes. How many have tried vitamin C and it didn't work? Is that every time?
In what quantities? 100 milligrams a day intravenously for 3 days. 100 grams, sorry, a day, 3 days intravenously. Seems like a lot.
And okay, so it didn't work for someone.
Just curious, I still take a lot, but you know.
I think I've seen the case that Bob talked about where you take vitamin C, but the disease carries on and has its course, so it doesn't knock it out every time, I don't think. But in most cases, from my experience, it gets it mostly within a day. If I feel like I'm going to flu, if I really hit it hard that day, I'm pretty good the next day. I keep up taking a bit of vitamin C. Okay, my question is for my friends who don't have all the advantage of this sort of environment, and when I talk to them and I tell them that cholesterol may not be a big problem, they're like shocked, of course, right? So my question is there any evidence that lowering cholesterol using statins saves lives, or maybe takes lives? Because most MDs out there are telling the public that it's saving lives. And a secondary part of that is there any evidence that lowering cholesterol by any means saves lives?
Talk about the sweet Redox, whatever his name is.
This is one of these questions that, if I had one of these encyclopedic minds where you say, okay, and rattle off 5 different references. I never had that. But what I find is a lot of times to get to the answer that you're looking for, Mike, there's almost an intentional obfuscation in the literature because they don't really want you to know that the answer really is probably doesn't. And so I kind of cheated because I didn't know one of these things might be asked tonight. And there was a review, sort of a meta review. And again, it really depends on how you look at it. What's your endpoint? What was the endpoint of the study? What their statistical analysis was, the way they framed it. It just gets so obfuscated, but the endpoint was that statins probably reduce cardiac events. It doesn't have anything to do with mortality. But again, it's, are we looking at lipids? Are we looking at triglyceride? Are we looking at LDL? I just think it's so difficult to answer this question that it comes down to my own personal opinion, and everybody else can have their own personal opinion, that I think this is still really basically a triumph of marketing more than this is a triumph of science.
Okay, should we stop there?
No, you have one down to 11, right?
Okay, we'll have Dave's last question.
One question I'd like to raise.
I read. We're just going to have the last question. Go ahead.
So I've read a lot about taking C with lysine and proline,
And I wanted to get just a little bit of quick feedback as to the ratios of those that you would recommend, and also whether proline is that important or whether C and lysine alone will do it for most people who are reasonably healthy.
Well, first of all, Rath is the one who promoted that. And my thing with vitamin C is I'm always trying to figure out what the bowel tolerance is. And for older people, I take them up to bowel tolerance and then drop them down maybe 10% below that to find it, and that's optimum dose. And the amount of lysine I give them may depend upon whether or not they have any herpes or anything like that. I have not thought it necessary to use proline, but that's a debatable subject. And so anyway, the thing is that I think that these massive doses of vitamin C short-circuit these things, and it's not exactly a natural thing. I'd like to point out that we can fly higher and faster than birds. We've gone to the moon and so forth like that. And so we shouldn't be confined to the amount of vitamin C that even animals make. We can make far more vitamin C than a dog can, and we just have the brains to do it. So we can really eliminate free radicals. And when you eliminate free radicals, you really slow down the aging process considerably. You know, and this thing about diet, I'd like to say that I think that the real poison is sugar. I mean, about 1972, I started putting everybody on a no-sugar diet, and that has stood me in good stead ever since. And I have a particular subset of patients. I agree over here that the biochemical individuality is absolutely important. But I have a subset of patients, the majority of my patients are women with chronic candidiasis. And I got to tell you, when you have chronic candidiasis, you don't even want to eat fruit. And I hate to say that, because fruit would ordinarily be good for you. But you've got to really keep the sugar down if you have chronic candidiasis. And I find that these people have thyroid troubles, and they have heart troubles, and they have cognitive troubles. Absolutely. By the way, I saw on the internet today a reference that said that people who had low serum or high cholesterol, serum cholesterol, had less Alzheimer's disease. And you know, you'd think that cholesterol is sort of the insulation of the brain, so that doesn't surprise me at all. And well,
I don't think there's any data on proline. All I can tell you is that if your body can't make it, you're not going to get it from your diet. In other words, the content of proline in regular protein is a fraction of a percent, whereas in collagen it's 30%, and so there's a discrepancy there. So I don't know of any high proline proteins other than collagen itself, collagen and elastin. So I just tell people, when in doubt, take it. If your life is on the line, the cost of adding the proline is potentially worth it. And so once you resolve your aneurysm or other immediate crisis and you're now in a stable position, maybe you can drop the proline for a while and just see if something happens.
We didn't get a quantity yet. You asked a quantity.
Sorry?
You asked for a quantity number, like how much?
There's no potency, 5 grams of proline.
On red site it says 6 grams of vitamin C, at least 6 grams of lysine, 2 grams of protein.
Cool, thanks.
Okay, before we wind up, I just want to remind you that next month we're going to have Ray P, PhD.
Don't miss it.
He's one of the best. He's the fellow that really discovered bioidentical progesterone, turned John Lee onto it, and John Lee was one of our speakers back in the 90s and important person in this group. He also was an advocate and still is an advocate of coconut oil, and resisted that whole marketing thing that happened. He's just a fantastic guy, one of a kind, so don't miss him. And we'll be here again the third Thursday of October. So thank you for coming, and thank you, Tom.
All right, you back to Jake.